Welcome to our video on cervical insufficiency. We're going to go through the introduction and also the risk factors, clinical presentation, and then the diagnosis and management of this condition. So let's start with the introduction. Cervical insufficiency refers to painless dilation of the cervix during the second trimester of pregnancy in the absence of uterine contractions. As the cervix dilates, those fetal membranes will bulge through the open cervix, and that increases the risk of preterm delivery. But what puts the patient at risk for having cervical insufficiency? Well, surgical procedures like cervical biopsy and dilation and curettage, or DNC, are the most common causes of cervical insufficiency. Then cervical trauma, such as cervical lacerations during a previous pregnancy, can also weaken those cervical tissues. And lastly, exposure to diethylstilbestrol in utero. So in other words, when the mother was a fetus and was exposed to this estrogen, then that can result in some structural abnormalities, especially of those reproductive organs, including cervical insufficiency. Now, patients are mostly asymptomatic, which makes sense because, as we mentioned before, it's a painless dilation of the cervix. But some patients can actually have some non-specific symptoms like mild pelvic pain, mild back pain, and even vaginal discharge. And patients with cervical insufficiency usually have a history of prior pregnancy loss, and that could go undiagnosed. And as we mentioned before, that weakened and dilated cervix really puts your patient with this risk of preterm birth, because you want that cervix to stay closed during pregnancy until it's time to deliver. If it doesn't, you got this risk of preterm birth. Now, cervical insufficiency is often a clinical diagnosis, so there would be a history of 2 or more prior mid-trimester pregnancy losses, and those are commonly before 24 weeks of gestation. Also, cervical length measuring less than 25 millimeters, which you would measure on a transvaginal ultrasound, would also support the diagnosis. So what do you do for these patients? Well, you manage this with cervical cerclage. This is a procedure that uses sutures for cervical reinforcement during pregnancy. You're just helping tighten that up. So where it was open, you bring it closed. And those sutures are placed at the cervical vaginal junction or at the level of the os. And you actually want to do that early. So this is at 12 to 14 weeks of gestation. So here's an image showing a cervical cerclage. So you can see the cervix down here, and then where we've circled, you're just bringing that together. Okay, let's wrap up with a question. A 33-year-old G3P0 female at 13 weeks of gestation comes to the physician for a routine prenatal visit. She has a past medical history of painless loss of her first 2 pregnancies at 14 and 16 weeks of gestation, respectively. Her vital signs are unremarkable. The physical exam reveals a dilated cervix. What is the next best step in the management of this patient? So this is fairly straightforward based on what we've just talked about. The patient has painless loss of her first 2 pregnancies, and on physical exam, you can see a dilated cervix. So both of those findings are consistent with cervical insufficiency. So the next best step in management is to give a cervical cerclage. And that concludes this section.